Hello everyone. I am myself Dr. Rajesh Gubba. I am the general medicine educator. So as we are approaching the INI-CT exam in the month of November, so in order to cover the revision of general medicine, I have come up with the INI-CT revision series, and today will be the first session. And in everyday sessions, I'll try to cover some important topics. So in the today's session, the topics which I'll be covering is approach to Cushing syndrome and some new pattern of questions, that is extended match the following, wherein I'll be giving you different clinical scenarios of epilepsy, and then I'll be giving you different clinical scenarios of anemia, and I will also discuss the various abnormalities of the tongue morphology and approach to Sheehan syndrome, and then I will also discuss about the hypothyroidism. So these will be the topics I'll be discussing in this session. So the first clinical scenario is a 60-year-old male presented with skin hyperpigmentation, central obesity, violet striae, and proximal myopathy. Blood pressure is 160/90. Laboratory studies shows hypokalemic metabolic alkalosis. Which of the following statement is true regarding this condition? The options are: basal ACTH level is likely to be low, circulating CRH is likely to be elevated, pituitary MRI will visualize all ACTH secreting tumors, serum potassium level less than 3.3 millimoles per liter is suggestive of ectopic ACTH production. So now, what is this clinical scenario? First of all, it is suggestive of this clinical scenario. It is suggestive of the Cushing syndrome. So now, how can you tell that the patient is suffering with the Cushing syndrome? Because the individual is having central obesity, right? Violet striae is there, and then proximal myopathy is also there. So now this Cushing syndrome, like how do we classify the etiology of Cushing's? We classify this etiology into ACTH dependent type of Cushing's and ACTH independent type of Cushing's. So these are the two important types of the etiologies. ACTH dependent type of Cushing's, again we have two important etiology, that is pituitary adenoma, that is corticotroph type of pituitary adenoma, and then ectopic ACTH producing tumor. Whereas ACTH independent type of Cushing's, if you see, right, we have two important tumors, that is adrenal adenoma, and then next, like what we have is adrenal carcinoma. So these are the two important etiologies that will be causing ACTH independent type of Cushing's. Now in ACTH dependent type of Cushing's, there is increased ACTH, and in ACTH independent type of Cushing's, right, the ACTH will be reduced because of negative feedback mechanism due to excessive cortisol production. And in ACTH dependent, when ACTH is producing in excess quantity, even MSH is also produced in excess quantity here. So because MSH is produced in excess quantity, these individuals will have the hyperpigmented skin. Whereas in ACTH independent type of Cushing's, there is decreased ACTH. So that is the reason why there will be decreased MSH, and due to which there will be hypopigmented skin in case of the ACTH independent type of Cushing's. Now, our patient is having the skin hyperpigmentation. So definitely it should be ACTH dependent type of Cushing's. So we will rule out these etiologies causing Cushing's. Now, the next important point is, like basal ACTH level is likely to be low is a wrong statement, because in ACTH dependent type of Cushing's, the ACTH levels, they are elevated, and circulating CRH is likely to be elevated. That is also an incorrect statement. So if you take the ACTH dependent type of Cushing's, where ACTH levels are elevated, when ACTH levels are elevated, that will inhibit the CRH which is coming from the hypothalamus, and CRH levels should be low. So this is also an incorrect statement. Now, pituitary MRI will visualize all ACTH secreting tumors. Remember, pituitary MRI cannot visualize the pituitary adenoma of size less than 2 mm. So that is the reason why this statement is also wrong. Now, in which type of Cushing's you have the serum potassium levels less than 3.3 and metabolic alkalosis is being present? That is seen in case of ectopic ACTH producing Cushing syndrome. Now, what are the sources of ectopic ACTH? Most common cause for ectopic ACTH is small cell carcinoma of the lung. The other sources are pheochromocytoma, medullary carcinoma of thyroid, and then pancreatic and bronchial carcinoids. So, ectopic ACTH producing Cushing syndrome, that will cause hypokalemic metabolic alkalosis. This hypokalemic metabolic alkalosis is seen in pituitary adenomas and as well as ectopic ACTH. But most significantly, they are seen in case of the ectopic ACTH producing Cushing syndrome. Okay, so the answer is the fourth option. Now, how it will cause hypokalemic metabolic alkalosis is when steroids are produced in excess quantity, this excess steroids will go and stimulate the epithelial sodium channels. Right, will go and stimulate the epithelial sodium channels. So when epithelial sodium channels are stimulated, there will be increase in sodium and water retention. Right, there will be decrease in K plus and there will be decrease in your H plus, and this will cause the hypokalemic metabolic alkalosis. Next, you see the next important clinical scenario. So this is like a new pattern of question which is like extended match the following type of question. So here I'll give you different clinical scenarios along with the options as well, and basically this question is about the investigations in a case of the epilepsy. The first clinical scenario you see here, 53-year-old obese man presents with sweating, tremor, drowsiness, fits and agitation. His wife denies any history of the alcoholism. So what is this clinical scenario very much suggestive of? Presence of sweating, tremor, drowsiness, fits and agitation. All these, they are suggestive of the hypoglycemia. So all these features, they fit for hypoglycemia. So in case of the hypoglycemia, what do you think would be the ideal investigation? Like you need to check for the blood glucose levels. And you take the second clinical scenario. A 12-year-old girl is brought to the accident and emergency department by her parents complaining of persistent rash, photophobia and as well as the neck pain. So presence of photophobia and as well as neck pain. So this tells the individual is having some sort of meningitis. Neck pain, you can have neck pain in the sense like neck stiffness. The differential diagnosis is subarachnoid hemorrhage. But in patients with subarachnoid hemorrhage, you will not have photophobia. So now you are suspecting meningitis in this case. Now what would be the cause for meningitis you are thinking? It is Neisseria meningitis. Why are you suspecting Neisseria meningitis? Because the individual is also having the persistent rash. And that is the reason why we need to suspect Neisseria meningitis. So now in this clinical scenario, when you are suspecting meningitis, what would be the ideal, right? What would be the ideal investigation? That is the lumbar puncture. Okay. Now you take the third clinical scenario. A 35-year-old mechanic has recurrent epileptiform attacks. He has no history of trauma. So what would be the cause for your recurrent epileptiform attacks? That would be intracranial space occupying lesion, or if there is any infections within the central nervous system. So how will you identify the intracranial space occupying lesion? That is by doing the CT scan of the brain. So the ideal investigation first that you need to do here is the CT scan of the brain. And you take the fourth clinical scenario. An 18-year-old student is brought to the accident and emergency department by ambulance having been flung off his bicycle in a road traffic accident. Upon arrival, he is noted to have deterioration in the consciousness. So what is that you will suspect in this individual when there is deterioration in the consciousness along after a head trauma? So either you should suspect the subarachnoid hemorrhage, right, or some intracranial hemorrhage. So either subarachnoid hemorrhage or any sort of intracranial hemorrhage, like you take subdural hemorrhage or extradural hemorrhage or intraparenchymal hemorrhage. So how will you diagnose? What would be the first important investigation? That is CT scan. So in this question also, in this clinical scenario also, the ideal investigation that you have to do first will be CT scan. And you take the fifth important clinical scenario, headache, drowsiness, seizures and rising blood pressure. So all these clinical scenarios are suggestive of what? Headache, drowsiness, seizures and rising blood pressure. So boxer, there is drowsiness and as well as seizures. Drowsiness and seizures suggest that the individual is having some pathology within the brain parenchyma. right? The individual is having some pathology within the brain parenchyma. Along with that, headache and as well as rising blood pressure. So this tells that the individual is having headache because of raised blood pressure, due to which there might be intracranial hemorrhage. So how will you identify that? By doing a CT scan. So these are the clinical scenarios and the respective investigations that has to be done on a first line basis. Next. So the another question is also like the clinical scenarios, and as well as you need to match what is the cause of anemia, right? So I have given you different clinical scenarios and you need to know like what is the cause of anemia there. An 8-year-old boy presents with painful swelling of hands and feet, jaundice and anemia. He is noted to have splenomegaly and his blood film has the target cells. Now see, the individual is having jaundice, anemia, target cells. So what does this tells you? This tells you the type of anemia should be a hemolytic anemia. Why are you suspecting hemolytic anemia? Because of hemolysis there will be excessive release of hemoglobin that can get converted into bilirubin, because of which the individual will have jaundice. And in hemolytic anemia you will also have the presence of target cells. So what is the clinical scenario where you will have the target cells? In the clinical scenario given is sickle cell anemia. And because in sickle cell anemia you will have swelling of hands and as well as, right, swelling of hands and as well as the feet. Now what is the differential diagnosis for the target cells? Target cells can also be seen in patients with the thalassemia, but in patients with the thalassemia you will have persistent fetal hemoglobin, right? And swelling of hands and feet is not seen in case of thalassemia. So that is the reason why the best answer here is sickle cell anemia. And you take the second clinical scenario. 6 months old baby boy presents with severe anemia and failure to thrive. His blood film shows target cells and hypochromic microcytic anemia, and fetal hemoglobin is still persisting. Normally after the birth of the baby, what should happen to the fetal hemoglobin? Fetal hemoglobin slowly disappears. And our patient is having microcytic hypochromic anemia and target cells. So this is very much suggestive of thalassemia. Because the another important differential diagnosis for microcytic hypochromic anemia is iron deficiency anemia, but in iron deficiency anemia you will not have the target cells. So this clinical scenario is very much suggestive of the thalassemia, right? So the answer is J. Now you take the third clinical scenario. A 40-year-old woman presents with fatigue, dyspnea, paresthesia and sore red tongue. Blood film shows hypersegmented neutrophils, MCV more than 110 femtoliters and low hemoglobin is present. So MCV is more than 110. See, how much is the normal MCV? Up to 100 is the normal MCV. Our patient is having more than 100. That tells that the individual is having macrocytes or megaloblasts are there within the peripheral smear. And along with that there is also hypersegmented neutrophils. So the megaloblast with the hypersegmented neutrophils, that tells you B12 deficiency. Now another important point telling you that the individual is having B12 deficiency is presence of paresthesias and as well as the anemia. So fatigue and as well as dyspnea, right? Fatigue and as well as dyspnea, this is suggestive of anemia. Right, these 2 points are suggestive of anemia, features of anemia, and paresthesias, they are due to B12 deficiency causing peripheral neuropathy. So the answer here is the B12 deficiency, right? So the answer is A, right? And you take the fourth clinical scenario. A 60-year-old man post gastrectomy presents with macrocytic anemia. He drinks alcohol regularly. Now he drinks alcohol regularly, that is your that can cause B1 deficiency, but B1 deficiency will not cause macrocytic anemia. So here it is again B12 deficiency. Why? Because once the individual had undergone post gastrectomy, like once you have done gastrectomy, the parietal cells might have been taken off. Because the parietal cells have been taken off, that will cause the deficiency of the intrinsic factor. So because of the deficiency of the intrinsic factor, the vitamin B12 from the stomach cannot be carried up to the level of the ileum. So because of the deficiency of intrinsic factor, the individual will develop B12 deficiency. So the answer here is again B12 deficiency. Now you take the fifth clinical scenario. A 22-year-old Greek man presents with rapid anemia, jaundice following treatment of malaria. He is noted to have the presence of the Heinz bodies. So, like one of the very important anti-malarial drug is the quinine. So, quinine, when you give in patients with G6PD deficiency, that can cause the hemolytic anemia, or that can cause hemolysis. So after giving quinine, if the individual has developed the anemia along with jaundice, that means the individual has developed hemolytic anemia, right? And in which patients will develop hemolytic anemia after giving quinine? That is in patients with G6PD deficiency. And another very important point is the presence of the Heinz bodies. That tells you very much suggestive of the G6PD deficiency. So here the answer is I, right? That is glucose 6-phosphate dehydrogenase deficiency. So this is about the causes of anemia in the clinical scenarios which has been given to you. Next. Now, so like this is a question on the variable morphologies of the tongue. So like we have a 25-year-old man comes to you concerned about the appearance of the tongue, which he states has developed changing patterns over the past few months. He has no pain or associated symptoms. What is the most appropriate next step? Now the options are: reassure the patient that although there is no effective treatment, the condition is benign, right? And second option, prescribe nystatin and ask him to swallow 4 times per day. Treat with topical corticosteroids. Biopsy the lesion for a definitive diagnosis. See, basically, like what is the diagnosis? If you see, the patient is telling that there is changing pattern over the past few months. That tells you this is a classical case of the geographic tongue, right? Or the another name for this particular geographic tongue, it is also called as benign migratory glossitis. So what exactly happens? Why does this appearance you will have is that is due to rapid destruction and regrowth of filiform papillae is the one which will be responsible for benign migratory glossitis. And this is the one, rapid destruction and regrowth of the filiform papillae is the one which will cause changing patterns on the tongue. See, most of these patients, they remain asymptomatic. Then what would be the cause for this geographic tongue is the individual might be consuming spicy food. The individual might be consuming excess amount of alcohol. The individual might be a smoker, or the individual might be consuming an irritant to cause this condition. So what exactly is the cause is not known. But what do you think is the differential diagnosis for this geographic tongue? The differential diagnosis include lichen planus, leukoplakia, Ritter syndrome, pustular psoriasis, and even drug eruptions. So, right, and then how do you come to a diagnosis? See, you will come to a diagnosis of this clinical scenario by a continued observation, right? And you have to look for the changing patterns of the geographic tongue. What is the advice that you have to give to this patient? You should give him an advice to avoid smoking and ingesting irritant foods. And the only thing that you will be telling to this patient is the patient should be reassured and the condition is benign. So no treatment is needed at this point of time. Okay. So this is what you need to give the advice. Now, let me at the same time give you the morphologies of the various tongues. Presence of white patches over the tongue. Where will you see that? That you will see in case of the candida infection, wherein you need to give antifungal drugs. Where is that? You will have black and hairy looking tongue. You will have that in case of yeast infection, that is fungal infection, diabetes mellitus, cancer therapies, and poor oral hygiene. These are the differential diagnosis for black and hairy tongue. Where is that? You will have red and white spots. Remember, you need not worry about the presence of red and white spots. So this tells you that the taste buds have worn down. So no worries, there is no need to treat it, and it's fairly a common condition. Presence of redness over the tongue. So presence of redness over the tongue tells you it is deficiency in folic acid, B12, or the iron. Okay, so or even it may imply the fever or the streptococcal throat infection. And where is that clinical scenario? You will have webbed or striped looking tongue. So it's a chronic condition like called oral lichen planus. It is caused by your immune system attacking the cells. There you will get this webbed or striped looking tongue. Presence of ridges. See, this is the result of teeth pressuring into the tongue or pressing into the tongue. So mainly when you are asleep. So you need not worry, they disappear it by own. But the presence of these particular bumps, right, the presence of these particular bumps. So the presence of the bumps tells you it is like canker sores and the herpes, which are basically the cold sores. So this is about the presence of the variable morphologies of the tongue. Next, coming to the next important clinical scenario. A female undergoes uneventful full-term normal vaginal delivery. After a few hours, she started complaining of severe headache and visual changes. She is found unresponsive after 4 hours. She is intubated and on examination, blood pressure is 64/30 and heart rate is 160 per minute. Laboratory studies shows random blood glucose of 45 milligrams per deciliter with normal hemoglobin, WBC and platelets. Which of the following you will use to manage this patient? The options are activated drotrecogin alpha, hydrocortisone, piperacillin tazobactam, transfusion of packed RBC. Now, all these events, if you observe in the patient, has developed after the normal vaginal delivery. So it's a postpartum event. The individual is having severe headache and as well as visual changes, unresponsive, and hypotension is there, and also hypoglycemia is also there. So all these features, they are suggestive of the hypopituitarism, right? So particularly if you take hypotension and as well as hypoglycemia, that is because of the ACTH deficiency. And you take the severe headache, it would be because of the pituitary infarction or pituitary hemorrhage. Visual changes are also because of your pituitary hemorrhage. Now, when you are suspecting hypopituitarism after a normal vaginal delivery or after the delivery, what is that you will be thinking of? Like, it is the Sheehan syndrome. And one of the important multiple choice question is, what is the first important hormone that is reduced in Sheehan's? That will be growth hormone. And what is the first important hormone that you need to be supplementing in patients with the Sheehan's? That will be steroids. Okay, so after growth hormone deficiency, the next one is the gonadotrophins. Right, there will be decrease in your FSH and as well as the LH. And the next important is there will be decrease in the ACTH. Right, there will be decrease in the ACTH. So these are the first hormones. First hormone to be reduced is growth hormone. First hormone that reduced is growth hormone. Okay, but first hormone that you need to give for the treatment is you need to give steroids. Okay, so that is the reason why the answer in this question is the hydrocortisone. What about your drotrecogin alpha and as well as piperacillin tazobactam? See, drotrecogin alpha and as well as the piperacillin tazobactam you should give if you are suspecting sepsis in the patient. And transfusion of packed RBC, if you observe there very closely, the individual is having normal hematocrit, that is normal hemoglobin, WBC, platelets are there. So transfusion of your packed RBC is of no use at this point of time. So in patients with Sheehan's, right, the first important hormone that need to be supplemented is steroids. So that is the reason why the answer is the hydrocortisone. So these are some of the very, very important clinical scenarios and as well as new pattern of questions and some image based questions. So you can just tell me in the comments box like which topics you want me for the revision. So those topics I'll try to take up for the revision in the upcoming sessions. Thank you very much. See you tomorrow again.